This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Matt Barrett from Virginia Commonwealth University, and today I'm interviewing Michael Okun from the University of Florida. Michael, thanks for joining me today. We're going to be discussing your paper that was recently published, Tapping the Brakes on New Parkinson's Disease Biological Staging. So in this Viewpoint article that was just published in JAMA Neurology, you all talk about how there should be caution and deliberation as we embark on this new era of understanding Parkinson's disease as it regards the biomarkers that have become available. It's on the heels of these two recent publications in February that proposed both a new biological definition and a new biological classification. For Parkinson's, both of these were efforts undertaken by large groups of researchers from institutions across North America and Europe. One of these articles was called A Biological Definition of Neuronal Alpha-Synuclein Disease Towards an Integrated Staging System for Research, and the other was titled A Biological Classification of Parkinson's Disease, the Synergy Research Diagnostic Criteria, Synergy standing for SYN of alpha-synuclein or pathological alpha-synuclein, NER of neuronal degeneration, and G of genetic contribution. And before we really dive into the details of your recent response Viewpoint, what is the most important message that you want to try to convey in this paper?
I think the main message here is that we know from cancer researchers, we know from other degenerative disease researchers like in Alzheimer's disease, that these things take time. And there's real concern in the field that if we rush too quickly, for whose benefit will it be if we rush at trying to establish a biological definition, we rush at staging systems without asking the right questions, and we get there a little bit too soon. And so I think it's very exciting, but our message isn't that we're not super excited as well, just like everybody else. It's that let's tap the brakes, not slam on the brakes. Let's tap the brakes and make sure that we've got the right dialogue happening, and also let the field evolve in the background, because there's lots of cool things that are happening now that are going to affect what we might use for biological staging and classification systems.
I think one place that's good to start here is to talk about really how we got to this point. Why is there any effort at all to redefine a biological definition of Parkinson's or classification? And as your paper points out, it really has to do with the emergence and the validation and availability of biomarkers for pathological alpha-synuclein. I think this is really exciting for the field, as I think many do, probably one of the greatest advances in the last 15 years. But we know that pathological alpha-synuclein or alpha-synuclein pathology has long been recognized as an aspect of Parkinson's disease. So it's not entirely a new idea. The idea that we can measure it is. So I guess I just wanted to speak about why now? Why do you think the criteria are coming out now? What do you think the motivation is that we redefine Parkinson's at this point?
I think it actually dates back to the early 2000s when several researchers were really interested in developing a marker or a biomarker for mad cow disease. We call it prion disease, but in the press they call it mad cow disease, right? And so they were looking at ways that they could detect the mad cow disease, and they were using all sorts of different laboratory techniques. And there was this search and lots of development that was happening in the laboratory where folks were saying, okay, what if we tag these things called prions, these proteins called prions, and then we shake them up? And when I say shake them up, really shake them up, we were talking about going for 20 hours where you vigorously shake these things and then see if you can actually tag where these proteins were and come up with a test to show these people have prion in a particular fluid, like blood or in cerebrospinal fluid. And so this was really a couple of decades of work that had happened. And what we have been able to do in neurodegenerative diseases is translate these types of advances directly into looking at other proteins like alpha-synuclein. And so the synuclein assay, which multiple investigators have been working on for many years, has really, brought to the forefront this idea that, hey, we could be closer to looking at some of the biology of this disease. And if we could biologically define it and diagnose it, and even better, if we could figure out ways to track its progression, we could really accelerate clinical trials. We would need less people to enroll. We could have cleaner studies and hopefully get to therapeutics a little quicker. Other fields are ahead of us in cancer and in Alzheimer's disease, so in some ways it's just a matter of time, but we should really thank our prion colleagues and then several generations of folks in the Parkinson world for adapting some of these techniques to synuclein, which is that protein we find in Lewy bodies.
And I agree with that. I think you're pointing out that the new redefinition and reclassification, or these efforts, are the next logical step in a real progression that dates back a couple decades and then also borrows from not only other neurodegenerative disease, but even other areas of medicine like cancer. Now I want to take a look at your Viewpoint article, which I think is really just a response to these new classifications. And as you all point out, there are some similarities between the two papers that were published, but there are also some differences. And I think the differences reinforce one of the points of your paper, which is there are some unsettled questions in the field. What are some of those key differences that you all identified between the two criteria and really probably points that deserve greater discussion?
First of all, I congratulate both of the groups for coming forward and really bringing out points and trying to create a dialogue about what a classification system should look like, particularly a biological classification. And there's overlap between the two systems, particularly in this idea of a biological definition. And of course, that is driven mainly by this synuclein assay that we talked about that was born out of the prion history. Now, what we do see are some differences between the two approaches. And there's a great article that accompanied these two. There were actually 3 editorial Viewpoint types of articles that accompanied the original 2 papers, and those appeared in the Lancet Neurology alongside. And there's a wonderful comparison by Darwish and colleagues from the Netherlands where they lined up the two and they said, what are the differences and where do they overlap? The main differences, Matthew, are in integrated staging systems. There seems to be one for the NSD versus the SYNRG. It doesn't have an integrated staging system. And the disease labeling between the two, the disease gets labeled neuronal alpha-synuclein disease in the NSD, whereas in the SYNRG, they still call it Parkinson's disease. Now, both of these techniques are falling short in identifying those early people. Do you have Parkinson if you don't have symptoms or not? And we're still, trying to decide how do we deal with those. The other is in the NSD criteria, if you end up having no synuclein positive on the synuclein assay, then you don't have this neuronal alpha-synuclein disease and don't have Parkinson's disease. You may have something else. And so it raised this whole specter of people beginning to say, oh, do we get rid of the eponym Parkinson's disease or not? And then you have to look at ways in which the investigators are going to dig in on which techniques. And so the NSD criteria used dopamine transporter scans, so-called DAT scans, didn't have other dopaminergic imaging modalities or non-dopaminergic imaging modalities, and the SYNRG had more of those being allowed. As time goes forward, of course, we're going to see more advances. And so I think any of these types of approaches are going to need some flexibility in how they're approached. But I think, Matthew, it really brings to bear many of the issues, challenges, and then, of course, adaptability, how, like with the ATN classification in Alzheimer's, they keep adapting, they keep changing, they keep making it better. So one of the main themes here that folks that are listening is that these should be, in progress. There should be not one staging system that stays the same. And even in Alzheimer's, just in the past month, we've seen an updated set of criteria. And so these should be in motion.
You're bringing up the ATN classification and then just the name of the integrated staging system for Parkinson's borrows some from recent efforts in Huntington's disease to have an integrated staging system, and then also obviously from Alzheimer's disease. I'm just curious what you think about how Parkinson's disease might deserve a different approach. Obviously, it's not one size fits all for these definitions and classifications, but obviously we need to borrow from the work done in these other diseases. Just for example, we have Parkinson's disease, that's a neuronal alpha-synuclein disease. But we also have dementia with Lewy bodies and many cases of REM sleep behavior disorder. I can see that as a difficulty or a challenge that faces the field of Parkinson's more than the other fields. I just wondered if you had some comments about that.
Matthew, I think that really gets at the heart of what a complex disease this is. Some people have said that when you consider all the medications, all the therapies, all the different forms of Parkinson, this might be the most complex disease in clinical medicine. An increasing number of us have begun embracing the idea that it's Parkinson's disease is plural, to acknowledge the real heterogeneity in the clinical and the pathological definitions and descriptions and phenotypes that we see. Now, I will say this. I think across all diseases, Matthew, we're beginning to appreciate that there's heterogeneity, more heterogeneity than we thought in cancers, more heterogeneity than we thought in other neurodegenerative diseases, in diseases in general medicine. And so I think this is really something that perhaps we're seeing it highlighted right up in our face in Parkinson, but I think other diseases will also have to deal with this. And so I don't think it's necessarily a negative that we have some extra things to think about. You brought up the REM sleep behavior disorder. We also have seen that the synuclein assay may miss a third or more of the folks that have Parkinson's. So you may have the LRRK2 mutation. It may not show up in the synuclein assay. There's a new paper about Parkin as well not showing up. And what do we do with these cases? And this just highlights a heterogeneity that we just have to deal with it. And we have to deal with it in real time. And so I don't think it's necessarily a negative. It's more reason to tap those brakes and create the dialogue.
One similarity I did want to point out that these articles were very clear about is that these were research criteria, not to be used in the clinical context. But of course, we work in a world where we face patients, and patients may hear about this and ask about it. And we also have the clinical availability of these pathological alpha-synuclein biomarkers, which I think in some clinical scenarios can be helpful. I'm curious about how you have found those biomarkers, if you've incorporated any of them into your clinical care, and if the criteria have come up in any clinical context that you've had to talk to patients about.
Yeah, the answer is no. And we are really not there for, at least in my mind and in my own practice, in putting these into any sort of use in the clinic. There has been real concern about using anybody's criteria right now for research. And part of that is that before you do that, you've really got to ask that question. Fundamentally, are we leaving anybody out? We can't leave anybody behind. And we think about ourselves in a very egotistical way, but it turns out that there are a lot of countries around the world. There are a lot of people that use the term Parkinson's disease, and so making sure that they have availability of these tests. And then if you put something in place, you might then exclude certain populations, even within developed and within low-income countries. You might exclude certain people from being able to participate or get access. And there are real challenges here, Matthew, that I think the people that are listening should be thinking about. And then finally, there was an article on movement disorders that really got to the heart of ask the question, why are you developing this? Do you want a biological definition, like you said, for Matthew, for research, for clinical trials? How is that going to affect regulatory systems? How will that affect access? Do you want a system so clinicians can communicate between themselves? Do you want a system where clinicians can communicate with the persons with disease and in that particular system? And then remember, the most commonly used staging system, which is different than a classification system, is still the Hone and Yar worldwide, and people use that for billing, and people use that for tracking, and people use that for research. And it's not an awesome scale, but you can see how the simplicity of that really caught on, and how if you put something out maybe too soon without all the information, it might stick. And so I think you have to be really careful, but some really thoughtful people that are thinking about these sorts of things. Okun, who is the lead author on the Tapping the Brakes article, really understands the low-income country question and the access question here, and has been a real leader in making sure that folks appreciate that.
And that is absolutely something I wanted to talk about, which are these potential unintended consequences that I think critical to think about as we redefine any disease. And certainly if we start requiring biomarkers for the highest standard of diagnosis.
It's really important that stakeholders are at the table. And when you talk about global access, you talk about these staging systems and everything. We're just at the beginning. This is, if it was the Bible, it would be like the first line or two of Genesis. We're really at the beginning here. I think one message is folks should realize you got to bring in the stakeholders. You got to get people on the bus with any sort of system and think about those unintended consequences.
Thank you for going over all of this. I think in closing, what I'd love to do is just have you share the main points of your article to leave that with listeners as we close.
Yeah, so the main points for folks to remember is that anytime that we develop a staging system for a disease, whether it's cancer, Alzheimer's, or Parkinson's disease, a lot of thought has to go into this. We need to make sure that we have all the stakeholders at the table and that we realize that we are in an environment that is dynamic. Things are changing. Tests are changing. The test that might be the one that is the latest and greatest today may be gone, like poof, tomorrow. We may be doing something completely different. As we move forward, we got to make sure that bus is going at the speed where everybody can get on. And we need to make sure that we are being very sensitive to underdeveloped areas and regions that may not have access, low-income countries. And also, when we talk about regulatory agencies, we don't want to overrepresent ourselves, so regulatory agencies start requiring it. And when we have the U.S. Food and Drug Administration, if we go too fast and they require everybody to do something, guess what? Everybody in the world follows the U.S. Food and Drug Administration. If you didn't know that, take that as a take-home point now. So if you go too fast and then they adopt something, it could end up leaving a whole bunch of people behind. There's a lot of work to be done. There's a lot of improvement on the assays. We're going to see more MRI scans. We're going to see more different modalities in blood and in other fluids. And so the idea that we'll be stuck with cerebrospinal fluid and spinal taps, this generation, it's only going to get better. We are excited, but we need to ask the right questions and move at the right speed. And we do congratulate the two authors of these papers, but we just think we need to tap the brakes a little bit on this and make sure that we get it right.
Michael, again, thank you for joining.
It's my pleasure. Thank you, Matthew.
If you would like to read more about this topic, the article we spoke about, Tapping the Brakes on New Parkinson's Disease Biological Staging, is available now at JAMA Neurology.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.